It is a warm summer night in 1819, and the room smells of tallow and roasted meat. Candles gutter, shadows breathe along the plaster. Around the table sit men in stiff coats, the sort of people who command roads and orders. And in one chair, Charles Lennox, the 4th Duke of Richmond, lifts a glass as if to a toast. Weeks earlier, he had been bitten on the hand by a fox. The wound healed. The story closed. Everyone assumed so. But when that glass tilts to his lips, his hand trembles, his throat spasms. He jerks away as if the water itself were a living thing. He wasn't afraid of the fox. He wasn't afraid of the bite. He was afraid of the water. And he wasn't the one making that decision.
Wow.
The guests think he is seized by sudden terror. Servants run for physicians. Friends lean in with concern. The muscles in his throat convulse. He chokes and gags, and within days he's dead. August 28th, 1819, buried in Quebec City. A powerful man, stripped of agency by something microscopic and patient.
Unnerving.
Unnerving. What does that image mean for us now? Break down what that bite actually staged inside him.
Yeah, Mara. So, at the most basic level, rabies is a lysovirus, part of the Rhabdoviridae family. It's a bullet-shaped virion, roughly 180 nanometers long, with glycoprotein spikes on its surface that let it bind to host cells. It loves neurons. It attaches, it gets in, and then it climbs, slowly and relentlessly, toward the central nervous system.
That image of the virus preferring the back roads is so useful. Most pathogens flood the bloodstream and confront immunity head-on. Rabies slips into peripheral nerves, the telephone wires of the body, and uses the cell's own motors to travel retrograde toward the spinal cord and brain. The immune system barely notices until it's almost too late.
Exactly. The virus replicates briefly in muscle near the bite, then it finds motor and sensory nerve endings, especially motor end plates. It binds to receptors like nicotinic acetylcholine receptors and NCAM, gets inside a neuron, and hijacks dynein motors to ride microtubule tracks back to the neuronal cell body, hand over hand, inch by inch.
Picture a burglar who doesn't take the busy street where cameras and patrols see him. He climbs the telephone wires, slow, invisible, inching toward the house. That's the retrograde axonal transport. It's a geometry problem. A bite on the face is a short commute. A bite on the ankle is a cross-country trip.
Right. And while that journey happens, the immune system is essentially blind. Neurons are immunologically privileged, and the virus travels inside cells, so antibodies and immune cells don't get a good look. That stealth mode is the real horror. You can feel perfectly fine while something is inching toward your brain.
That silence, the patient who feels normal, creates a terrifying possibility. The bite you shrugged off at a picnic, the bat you found in your bedroom and thought nothing of, it may have started a path you cannot sense, a path that, once symptoms begin, is almost always fatal.
We have to be precise about that. Once clinical symptoms appear, rabies is virtually 100% fatal. The World Health Organization writes that clearly. When the virus infects the central nervous system and clinical symptoms appear, rabies is fatal in 100% of cases. That's not rhetorical. It's the clinical reality.
So then, the fear of water, hydrophobia, what is that clinically? How does it feel to the patient? And what does it tell us about the virus's strategy?
Hydrophobia is a mixture of physiology and conditioned terror. The virus heavily infects brainstem regions, controlling swallowing nuclei that coordinate the pharynx, larynx, respiration, and cranial nerves 9 and 10. When the patient sees water or even hears it, those circuits trigger violent, involuntary spasms of throat and respiratory muscles. It feels like choking, burning, suffocating.
So the patient may beg for a drink and then scream when it's brought near because each swallow causes excruciating spasms. The fear is real because the pain is real.
It's not hysteria. It's a reflex arc reprogrammed. And there's also aerophobia spasms, triggered by air currents. The virus has retooled basic reflexes to make swallowing and even breathing agonizing, which, disturbingly for the pathogen, serves the virus's aim.
Yes, there's an evolutionary logic. Infect the salivary glands so saliva is loaded with virus, induce hypersalivation and difficulty swallowing so the host drools or spits instead of swallowing the virus into stomach acid, increase aggression so the host bites. All of these changes raise the chance that the virus will move into another mammal.
Parasite puppet master. Grim, but tidy.
It's grim and efficient. Most human cases, around 80% in many clinical series, present as what we call furious rabies: agitation, hyperactivity, aggressive behavior, hydrophobia, aerophobia, with periods of lucidity. About 20% present as paralytic rabies: insidious, progressive flaccid paralysis, less dramatic outward behavior, and easier to misdiagnose.
We remember the foaming mouth and the snarling because furious rabies is cinematic. It fit neatly into folklore. Which brings me, there's a long-standing idea that rabies contributed to vampire and even early zombie stories. Victor, how much of that is plausible?
It's plausible as a contributor. Rabid humans and animals bite, become nocturnally restless, have hypersensitivity, and can present with facial distortion or altered vocalizations. Those traits overlap with vampire lore: nocturnal roaming, biting, aggression. But vampire myths have many roots: burial customs, decomposition, Slavic folklore. So rabies may have intensified or colored those stories rather than invented them.
Interesting.
And zombie fiction borrows elements too: biting, biting-based contagion, rage. But rabies doesn't do everything fiction suggests. It doesn't reanimate the dead, and it doesn't grant superhuman strength. It's a real-world example of a pathogen that alters host behavior in ways that favor transmission, and that's eerily close to the rage virus trope.
Let's ground this in history again. The Duke of Richmond died in 1819 after a fox bite, one of many 18th and 19th century cases that framed rabies as hydrophobia and fed cultural horror. People had no virology. They told possession and curses. Pasteur would change that story a few decades later.
By the way, Mara, Pasteur's story is one of those rare, audacious wins in medical history. He used spinal cords from infected rabbits, dried them to attenuate the virus, and developed a regimen of injections of progressively more virulent material to train the immune system. In 1885, Joseph Meister, a 9-year-old boy who'd been bitten multiple times, about 14 times, by a suspected rabbit dog, received roughly 13 injections over 10 or 11 days and never developed rabies. That was the first effective post-exposure treatment for a viral disease in humans and helped found the Institut Pasteur.
Pasteur didn't make rabies ignorable. He created a race you could still win if you started running soon enough. That's the moral. Speed matters. The intervention we call post-exposure prophylaxis, PEP, is a race between the vaccine-induced immune response and the virus climbing the nerves.
Right. PEP involves immediate wound care, washing the wound thoroughly with soap and running water for at least 15 minutes, applying povidone iodine if available, then a series of modern cell culture rabies vaccines given intramuscularly on a schedule, and in severe exposures, rabies immunoglobulin infiltrated around the wound for immediate passive immunity. When given properly before symptoms, PEP is essentially 100% effective at preventing rabies.
It's almost cruelly simple. Those mundane acts, washing a wound for 15 minutes, getting a vaccine, stop a microscopic assassin. Yet globally, rabies still kills tens of thousands of people every year. The WHO estimates about 59,000 deaths annually, predominantly in Asia and Africa, and children under 15 account for roughly 40% of victims.
And the primary source of human rabies globally is domestic dogs, about 99% of human cases. So the public health solution is conceptually straightforward. Mass dog vaccination, better access to PEP, public education, improved surveillance. The WHO's 0 by 30 initiative aims to end dog-mediated human deaths by 2030 through those measures.
0 by 30. Ambitious.
Ambitious but achievable if we scale vaccination and access. The problem isn't a mystery virus, it's inequality of access and infrastructure. In high-income countries, rabies from dogs is effectively eliminated through mass dog vaccination and stray control. In many endemic countries, those systems are patchy or absent.
Let's bring in modern, haunting vignettes to remind listeners this is not just historical. Victor, one of the modern cases in the source material was an organ transplant in the US, right?
Yes. A Michigan patient died of rabies after receiving a kidney transplant from a donor who had an unrecognized rabies infection linked to a skunk scratch months earlier. Symptoms, tremors, confusion, difficulty swallowing began about 5 weeks after the transplant, and he died within a week of hospitalization. It was the first human rabies death in Michigan in about 15 years, and shows how a missed exposure history can let rabies hide even from hospital-level diagnostics.
Disturbing.
Also, a traveler case. Someone bitten by a dog in Ethiopia later developed rabies and died in Spain. Spain has been free of terrestrial rabies since 1978, so the infection came from travel. These cases remind us that travel and wildlife reservoirs like bats can challenge the assumption that you're safe in a rabies-free country.
Which brings up a common misconception. People assume they'd notice if a bat bit them, but bat bites can be tiny and painless. Public health guidance suggests that if you wake up with a bat in your bedroom, or find a bat in a room with an unattended child, or someone who can't reliably say whether a bite occurred, you should treat that as a possible exposure and consult health authorities.
Exactly. And another misconception, my dog looks healthy so it can't have rabies. Not so. Animals can shed virus in saliva briefly before overt symptoms. That's why pet vaccination is so important, and why local laws often mandate early immunization.
Also, wait and see is dangerous.
Yes, waiting is the risk. Once neurological symptoms begin, the odds are effectively zero. The small window where PEP works is before the virus reaches the central nervous system. That's why immediate wound care and timely vaccination are critical.
Let's talk about the clinical course in more detail, because the timeline itself is a kind of horrific architecture. Walk us through prodrome to death in clinical terms, Victor.
Sure. The prodromal phase can last days. Fever, malaise, headache, sometimes pain or paresthesias at the bite site, which is a very suggestive sign. Then the acute neurological phase begins. In furious rabies, you'll see agitation, hyperactivity, hallucinations, hydrophobia and aerophobia, and alternating lucidity and delirium. In paralytic rabies, you get progressive flaccid paralysis that may be mistaken for Guillain-Barré or other neuropathies. Terminally, patients progress to coma and cardiorespiratory failure as brainstem functions fail, often within 1 to 2 weeks of symptom onset.
Imagine the sequence: a mild fever, odd tingling at a scar, then insomnia, anxiety, a day when drinking becomes agony, then violent spasms at the sound of water, and finally, the silence of coma. That progression, fast, inexorable, is what makes rabies clinically devastating.
It also explains why some clinicians historically used provocative tests, blowing air on the face or showing water, to elicit spasms in endemic, low-resource settings. Those reactions are pieces of diagnostic evidence, cruel as they may sound.
The Milwaukee Protocol once raised hope that the fatal line could be crossed. Gina Gies survived in 2004 after a drug-induced coma and aggressive supportive care. But the protocol has been largely unreproducible. Other centers have tried, and most patients did not survive. It's a tragic lesson. One exceptional case doesn't make a reliable bridge.
Right. Gina's survival was extraordinary. She'd been bitten by a bat and didn't get PEP, developed symptoms, and her medical team tried an experimental regimen that included inducing a coma and antivirals to buy time. It worked that once, but subsequent attempts have mostly failed. The protocol is not a cure. It's a desperate, rarely successful intervention.
So, prevention remains the only dependable tool.
Exactly. PEP plus population-level dog vaccination. And pre-exposure vaccination for people at ongoing risk, veterinarians, wildlife workers, bat researchers, frequent travelers to endemic regions, simplifies later care and adds protection.
Let's be concrete for listeners. If someone is bitten or scratched by a mammal, what should they do, step by step?
First, immediate wound care. Wash the area for at least 15 minutes with soap and running water. Use povidone iodine if available. Second, seek medical care right away, urgent care, emergency department, or your physician. Be explicit, possible rabies exposure. Tell them species, where it happened, whether the animal is available for testing. Third, follow through with PEP, vaccine series, and rabies immunoglobulin infiltrated around the wound for Category 3 exposures. And if you have a known ongoing risk, get pre-exposure vaccination.
Also, capture or secure the animal for testing if it can be done safely and legally.
Yes, safely and legally, but do not endanger yourself trying to capture a wild animal. Public health departments can advise on safe capture and testing where appropriate.
We promised a few more vivid vignettes to echo the Duke's story, quick flashes across time. 1. A 19th century farmhand tied down because he tries to bite his attending nurse. The nurse shaken but unharmed. 2. A child screaming when a parent brings a cup, terrified because each gulp triggers a spasm. 3. A modern patient describing how just the thought of water or a draft produces an intense, choking panic. Clinically, the same pattern through centuries.
Yeah.
Let's expand on the science a bit more for listeners who like mechanistic detail. Retrograde axonal transport. What does that really look like inside a neuron? Use the analogy again, Victor.
Picture the axon as a long hallway with conveyor belts, microtubule tracks, running its length. Dynein is the motor protein that normally moves cargo back toward the cell body. Kinein moves cargo outwards. Rabies binds to receptors at the neuromuscular junction, gets inside the axon, and hops onto that retrograde conveyor, effectively hitching a ride with dynein toward the spinal cord and brain. It's slow. Estimates from animal experiments range around a ballpark of 12 to 24 millimeters per day, depending on host and circumstances. So a bite on your ankle could take weeks to reach the CNS, while a bite on your face might make the trip much faster.
The burglar who chooses telephone wires over the highway, again. Distance, viral load, strain, and host immune status all shift the clock. Rare cases show incubation longer than a year, so biology keeps reminding us it can surprise.
Let's talk reservoirs. Globally, dogs are the main source of human rabies, about 99% of cases. But in places like the United States, dog transmission is rare thanks to mass vaccination. There, wildlife reservoirs, bats, raccoons, skunks, foxes, are the primary sources.
That makes public health guidance context-dependent. In rabies endemic countries, dog vaccination campaigns are the frontline tool. In countries with controlled dog rabies, the focus shifts to wildlife, and particularly bats, because of those tiny, easy-to-miss bites.
And children are disproportionately affected worldwide. Around 40% of victims are under 15, because children are more likely to approach animals and less likely to report exposures. Education is a key prevention tool.
Which brings us back to resources and equity. 0 by 30 is the WHO's target to end dog-mediated rabies deaths by 2030 through mass dog vaccination, better access to PEP, public education, and surveillance.
It's a pragmatic, multi-sector effort, veterinary and human health working together. Where dog vaccination programs and responsible ownership are enforced, dog-mediated human rabies disappeared. Scaling that, funding, cold chain, workforce, community engagement, is the challenge.
I want to return to Pasteur for a moment, because his experiment is such a pivotal narrative beat. Joseph Meister's case is both dramatic and ethically complicated. Pasteur wasn't a licensed physician. He sought counsel from doctors before treating the boy. He used spinal cords from rabid rabbits, dried them to attenuate the virus, and injected the boy in a stepped regimen. The result? Joseph never developed rabies.
It was an audacious act that birthed a preventative paradigm. Pasteur's method wasn't perfect by modern standards, but it demonstrated that timely immune priming after exposure could prevent the disease, and that insight still underpins PEP today.
There is an almost mythic contrast there. Pasteur's wet lab and nerve-by-nerve biology versus the simple act of washing a wound in a sink. Both are part of the same arc, knowledge and practice saving lives.
Before we wrap, Mara, people always ask about the durability of human survivors and whether any reliable therapies are emerging. We must be honest. Beyond PEP, there's no consistently effective treatment once symptoms start. The Milwaukee Protocol gave us one survival, but it's not reproducible. A few other survivors globally have had unusual immune responses or partial vaccination before symptom onset. The bottom line remains prevention over cure.
Prevention, not miracles.
Exactly. And there are practical steps individuals can take. Keep pets vaccinated, don't feed or handle unfamiliar animals, teach children never to approach an animal that's acting strangely, and seek urgent care after any bite, scratch, or mucous membrane exposure to an animal's saliva.
If you travel to a country where dog-mediated rabies is common, consider pre-exposure vaccination. It simplifies post-exposure care and can be life-saving where access to RIG is limited.
And if you work with animals, vets, wildlife researchers, bat handlers, pre-exposure vaccination is standard. It's a professional safety net. It doesn't replace wound care and PEP, but it makes subsequent management easier.
Let's end where we began, with image and action together. The Duke of Richmond, powerful, accustomed to control, reduced by a microscopic burglar climbing telephone wires. The horror is real, but so is the counter-narrative. A sink, 15 minutes of soapy water, a clinic visit, a syringe in the arm, mundane acts that avert horror.
Hold the microscopic image and the sink both in your mind. One is terrifying because it's patient and invisible. The other is ordinary and powerful because it breaks the cycle. That's public health. Unromantic, persistent, and effective.
So the emotional arc we hope for is this. Yes, rabies is uniquely unforgiving once clinical signs appear. Yes, it has written itself into folklore and horror for centuries. But knowledge, swiftness, and basic public health tools make it preventable. Wash the wound, seek care, vaccinate animals, support mass vaccination programs. Those actions make the Duke of Richmond's fate an artifact of history rather than a present threat.
And practical reminders. If you wake with a bat in your room, consult health authorities. If a strange dog bites your kid, wash and seek care immediately. If you work with animals or travel often to risk areas, ask about pre-exposure vaccination.
It's oddly poetic. The virus that fears water, that engineers terror to survive, can be stopped by soap and a syringe. Strange poetry indeed, but not romantic. It's ordinary prevention, the kind that saves lives.
Totally. And for those who like history, remember Joseph Meister and Pasteur, an audacious intervention that founded a legacy. For clinicians, remember the Milwaukee Protocol lesson. One survival doesn't equal a cure.
Final practical line: support vaccination programs, keep your pet's records current, teach kids not to approach strange animals, and if exposure happens, wash for 15 minutes and tell the clinician possible rabies exposure. That phrase gets attention.
Amen to that. And if you're in health or animal sectors, push for better surveillance and PEP access in the communities you touch. The tools exist, they just need distribution.
So let the dread belong to the story, not to your life. If you do the small, unglamorous things, wash a wound for 15 minutes, vaccinate your pets, seek care, you turn a potential tragedy into a boring, solvable problem. The virus writes a frightening narrative across the nervous system, but public health writes a counter-narrative that's unglamorous, persistent, and effective.
Amen.
Thanks for joining us in this dark little exploration. I'm Dr. Mara Ellison.
I'm Dr. Victor Hale.
Stay curious, stay cautious, and wash the wound.